Hi, everyone. Welcome to another question and answer session with Dr. Drossman and myself. Today, we're joined by another wonderful guest expert, and we're going to be talking about pediatrics again today. We are joined by Dr. Julie Snyder, who's joining us all the way from Boston, Massachusetts. So hello to Dr. Snyder and hello to Dr. Drossman. How are both of you?
Hi, Johanna. Hi, Julie. How are you doing?
Good morning to you both. Thank you. I'm well.
So nice to have you here for this. We've actually collaborated on a really important paper on communication skills. And you are, as for those in the audience, Julie, Dr. Snyder is a director of GI Psych services at Boston Children's Hospital at Harvard Medical School. Very prestigious position, and we hope to learn a lot today. Tell us a little bit about yourself and what you're doing there.
Yeah, absolutely. I'm a pediatric psychologist and I'm fully embedded in the gastroenterology department at Boston Children's Hospital. My primary work is with patients with disorders of the gut-brain interaction. I work closely in the motility center with one of our gastroenterologists, Dr. Nurko, and then also see patients across the board in the gastroenterology department with an array of different diagnoses.
All right, thank you. So being embedded in a GI program, it really means that you're going to see all of the complex problems that the GI docs are looking for help with. So tell me, how do this GI psych treatments benefit children with DGBI? And maybe how is it different from adults, because we've heard about them.
Yeah, and so we really feel strongly that with pediatric patients, very similar to the adult patients as well, that we try to take a multidisciplinary and a holistic approach. And so we're not just looking, or we explain to the families that we're not just looking at their stomach or whatever else is going on in their digestive tract. We also want to make sure that we're looking at how they're coping with the symptoms that they're experiencing. And we also know that there's a very strong connection between the way that the brain perceives what's happening in the gut. And so when our gastroenterologist or when any pediatric gastroenterologist identifies that a child is experiencing really any type of symptoms, we want to make sure that we're involving whenever we can as psychologists. The treatments that psychologists are able to use are, multifold. I think one is that we really help to understand what might be exacerbating the child or the adolescent symptoms. And for some that might be different things. There may be dietary triggers. There may be levels of stress that are going on. There may be that the patient is not functioning at school, or something is going on academically or socially, or they're not exercising as much. So part of our role is to be able to help families identify that. And then the second part of our role is to be able to give patients and their parents strategies to be able to cope with or manage their symptoms. And I think it's really important that we always explain, or I always explain to families and to patients, that our goal is not necessarily to make the symptoms go away. We would love for that to happen over time, but our goal is really to help patients and families feel more confident in being able to manage the symptoms. And that's what those psychological treatments are aimed at.
Thank you. I'm curious, in adults, sometimes there are barriers to overcome when a psychologist is brought in. How do the children and the parents respond to you coming in to see them?
Yeah, I think that oftentimes sometimes they're a little bit confused, and sometimes it takes a little bit of explanation for why we are there. Again, I think one of our roles as a pediatric psychologist is to make sure that the family understands what their diagnosis is. So perhaps if they've been diagnosed with a disorder of the gut-brain interaction, such as irritable bowel syndrome or functional abdominal pain, we want to start our treatment by making sure that patients are have a solid understanding of what that means, and obviously tailor that to their developmental age. So we may explain, irritable bowel syndrome differently to a 7-year-old than we do for a 15-year-old. For a 7-year-old, it may be that their brain and their belly are just chatting way too much, and for a 15-year-old, we may be able to explain and get into more detail about that. So I think once we're able to explain that we're part of the medical team, helping the families understand the diagnosis that the gastroenterologist has made. And then again, really helping them to understand that why we're there is to give them active strategies to manage their symptoms. Most often they're accepting and willing to do the work with us.
You know, it's interesting, as you're saying that, your approach when they're younger is parent and child, with the parent taking sometimes a very active role, and then you have to transition them to the child or the adolescent.
Right. Right. It is. So it's interesting. If we're working with a younger child, it's making sure that the parents have a solid understanding of that diagnosis. And then it's making sure that parents also understand what what we're teaching. So if we're using components of cognitive behavioral therapy and the behavioral side, particularly, which really helps to learn those active strategies. So if we're using diaphragmatic breathing or a specific type of relaxation strategy, we know in those younger kids, it may be hard for them to implement on their own. So as a psychologist, we're maybe sending the practice file to the parents at the end of the session, and then having the parents, encourage the child to do it or do it with the child as well. Whereas adolescents, we're giving them more freedom and trying to give them more independence to practice those strategies on their own.
Yeah. So speaking of the treatments, what treatments work best? Do you have a way of partitioning out what you'll use for what condition, but based on the age or whatever it is?
I think that our overarching treatment is using components of cognitive behavioral therapy. And that treatment in particular, for those who may not be familiar, is really looking at how someone thinks about their symptoms and their GI symptoms in particular, and then how those thought patterns oftentimes can affect their feelings. And I always explain to patients and families that by feelings, we don't always mean like anxiety or stress or mood. We actually mean like what's going on in a GI tract too. And then ultimately how those thoughts and those feelings impact behavior. So are they going to school, or are they choosing to avoid school because of symptoms? And the way that I really determine what strategies might be best, I would say is based on the level of impairment in terms of symptoms. So if a patient is really doing a nice job of still functioning, though they're having symptoms and they're distressing to them, we may be able to do a briefer course of treatment that focuses on those relaxation strategies or those active coping strategies. If I'm seeing a patient who's really struggling, who's not able to attend school or not able to participate in sports practices, then we really want to take a deeper dive into kind of how you think about your symptoms and help them what we call restructuring of their thought patterns, in addition to those active coping strategies too. And the parents, because you've been focusing so much, which I think is really important on the parents, their goal, I always explain, is to become the coach of this process. So their goal is when their children are, whether it's a 7-year-old or whether it's a 16-year-old, that they're conveying, their child comes to them and says, I don't feel well, or my belly's hurting, or my stomach's bothering me. The goal of a parent is to be able to say, I hear you, to validate the symptom. I hear you that you're not feeling well. And what are we going to do about it? What are those strategies that you've learned with your psychologist, and what can we do in the moment?
So their role is to be part of the team and to influence or encourage them to respond to these strategies.
Exactly.
Do you ever get times where the parent's approach might be over-involved or over pathologizing or under pathologizing? How do you handle that kind of situation, or does it happen?
It does happen. It happens all the time. And I have a strong belief that I think that it's not intentional. I think that I always explain to moms and dads that, as parents, we think that when our child is not feeling well, we think of those natural things that we're supposed to do on a sick day, right? We're supposed to, maybe cuddle them if they're younger. We're supposed to allow them to miss a day of school to kind of regroup and, recuperate. However, particularly in the disorders of the gut-brain interaction, we actually know that type of assistance is counterintuitive. So what we want to do is we want to encourage parents to feel comfortable with the fact that their child's symptoms symptoms are hurtful but not harmful. So they are able to participate in activities. The gastroenterologist has let us know that it's safe for them. It's not going to harm their bodies. And so the parents are really kind of rallying and helping the patient to use those strategies, but also to promote that functioning too. And I oftentimes think if we as pediatric psychologists are able to take the time and explain that to families, most often the parents are able to get on board and help us. The adolescents sometimes aren't as happy when we say, like, your parents have been doing the right thing, of encouraging you to go to school. But I think over time, the whole family unit can understand it.
Can the parents ever involve school personnel to help in the overall care?
I would say more often than not. And so especially when children or adolescents are not going to school, parents are oftentimes already stressed because there are medical appointments and now there's all of these different providers involved. And so to set up something like a school reintegration plan, right, where we wouldn't expect a patient who is out for a period of time to jump right back into school, we know that pacing of that reintegration to school is important. So our team as psychologists, one of our roles, or if somebody is fortunate to have a social worker on the team, which we are, at my institution, we are reaching out to the school, to those school guidance counselors or those school social workers or adjustment counselors and saying, this is the patient's diagnosis, this is the treatment plan that we're recommending. So can we set up a reintegration to get the patient back to functioning? Or can they use, if they're struggling with symptoms in the classroom, we oftentimes will recommend in-classroom strategies that a patient can do. But then if they kind of reach the top tier of still not being able to cope, can they use the guidance counselor's office to go and use diaphragmatic breathing or progressive muscle relaxation and then return to class? So we do oftentimes use the school personnel.
Very good. I'm thinking you're at, one of the major pediatric GI programs. I'm curious about how you, in an integrated model, how you collaborate with Dr. Nurko and the others. You have conferences, or how do you integrate what you're doing with what they're doing with the child?
Absolutely. So I think that can happen in multiple ways. Pre-COVID, when we were just, in clinic all of the time, we were just there in clinic. And so our room where we see our patients, and it still happens now, was right next to the room that the gastroenterologist was seeing a patient. Or we would be able to travel into the conference room where all the gastroenterologists are sitting to be able to update. And so that's one easy way. Obviously, we do a lot of either phone or email communication with the gastroenterologist to make sure that happens as well. And then we actually are fully embedded into these multidisciplinary clinics. So in our functional abdominal pain clinic in particular, when Dr. Nurko, for example, does the history and the intake, I'm right there beside him. And so that sets that message from the very first time that a family walks in the room that this whole treatment process is going to be most helpful. So our nutritionist is there, myself as a psychologist is there, Dr. Nurko is there, our social worker is there, our nurse practitioner. So if you put that unified front, that helps the family, but it also helps us to continue to collaborate as a team.
Very good. Well, thank you. Any last words or take-home messages for the people out there?
I think just that these strategies work. And when a family is amenable and willing to participate in this treatment in conjunction with the rest of their team, we have good research that these patients go on to do just fine. And I think being able to give that family, of younger kids or even adolescents hope that we've seen these patients get better and improve with this multidisciplinary approach can really sort of shift the perspective, especially when families have been through so much.
Well, we greatly appreciate your insights. Johannah, do you have any words or any questions?
Yeah, no, I think this is so interesting. And I think it's, as Dr. Snyder said, it can be very stressful for families to have a child with a chronic illness. Even a DGBI that, kind of ebbs and flows with symptom severity can be really challenging and stressful. And so, that little tidbit of hope that these strategies do work and that we can see these kiddos go on to live full productive lives is really encouraging and important message to share. So thank you to both of you for being with us today. If you have any questions for Dr. Snyder, please let us know. We'll be happy to pass those along and get some answers for you. Until next time, everyone, have a great week and we'll talk to you next time. Bye, everyone.
Bye.
Thank you.